Hi, everyone. This is Mark Frazier from the Michael J. Fox Foundation. Thank you for joining us today for our first webinar of 2014. This year, we're starting something new. This is the first of our third Thursdays webinar. And you can log on every third Thursday of the month at 12 p.m. Eastern to hear discussion and ask questions about a particular topic important to Parkinson's disease patients, their loved ones, and the research community. So we hope you'll mark your calendars and join us each third Thursday. Today we're focusing on the long road to diagnosis and what researchers are doing to shorten that journey. Linda Keilman understands that journey. Linda is joining us from Indiana. She was diagnosed with Parkinson's disease in July of 2011 after a misdiagnosis of tendinitis. Also joining us today is Dr. Kathleen Shannon. Dr. Shannon is a movement disorders neurologist at Rush University Medical Center in Chicago and a professor of neurological science. Thank you, Kathleen and Shannon, for speaking with us. And also thank you to Dave Iverson. Dave is the Foundation's contributing editor and a member of our patient council, and he'll be moderating today and every third Thursday webinar. Before I hand it over to Dave, I just wanted to give a final thanks to AstraZeneca for their sponsorship of the 2014 Third Thursday webinar series. So without further ado, I'll turn it over to Dave Iverson. Dave?
Thank you, Mark, and good afternoon, everyone on the East Coast. Good morning for everyone in all other time zones, including my own here out in California. Thanks so much for joining us. And as Mark suggests, we're going to regularize the schedule for these and have these webinars every third Thursday going forward this year. As Mark was mentioning, the focus of this one is on the long road to diagnosis, and anyone who's a patient or a member of a patient family knows that long road well. And what we want to try to focus on today is where we are on that long road, what we're going to try to do to jump further ahead so that diagnosis isn't always such an arduous journey, and also why that's important, why getting an early diagnosis could be so central to how we go about not only managing the disease, but hopefully getting in on the disease sooner so that we're able to modify its course. So we want to begin with a story, really, and the story of a particular individual, and that's our guest, Linda Keilman. And Linda's a good example of that long road. And so, Linda, thank you again for joining us. And to begin by telling us what you first were experiencing before you knew that they might be symptoms of something else. What was it that you first felt?
First of all, thank you for having me, and it's my pleasure to be here today. It started with pain in my left shoulder, my neck, and my arm, but I had taught water aerobics for many years, and I thought that it was just a strain from pushing myself out of the pool, putting my arms behind me, and pushing out of the pool. The pain would come and go for years, and I'm talking about probably 10, 15 years ago, and it gradually just got worse, and the symptoms became worse, and I thought it was just a muscle spasm or something, so I did stretching exercises, yoga, massage therapy, chiropractic sessions, but nothing improved it.
And so you went to see a doctor about it, and who did you go see, and what did they say?
I went to an orthopedic surgeon thinking that something was wrong with my shoulder, and after examination he determined that it was tendonitis of the shoulder and inflammation of the elbow. And he prescribed 8 weeks of physical therapy, anti-inflammatory drugs, and ice therapy. And so I did that. And after he reevaluated me after the 8 weeks, and he said he thought that we needed to go a few more weeks and do some deep tissue stimulation, and he suggested that I get an MRI on my neck and my shoulder. And I did that. And then after...
And then it... Yes, go ahead, sorry.
I was just going to say, then after that round of therapy, he suggested that I go to a neurologist, which was a total.
And what was your thinking? Yeah, what was your thinking when he said that? What went through your mind at that time when he said, "Look, you should go see a neurologist"?
I thought he was crazy. I mean, there was nothing wrong with my brain as far as I was concerned. I was this healthy young, woman, strong, very active, with no family history of anything like that, and it just seemed like a silly idea.
And how old were you at the time, Linda?
Well, let's see. I'm 60 now, so I was probably around 53, 54.
So you went to see a neurologist at that point, and tell us what happened next.
I went to a local neurologist, and she was very abrasive and said to me, well, you know what, it's probably Parkinson's. Go have these tests and come back in 6 months. And that was just not going to work for me. Her doctoring style and my doctoring style needs were not going to be the same. So after procrastinating for a while, because again, I'm not going to accept the fact that there's anything wrong with my brain, I chose to go to the University of Chicago, to Dr. Z at the University of Chicago Movement Disorder Clinic. And that was the next step that I took.
And when you saw that movement disorder specialist, what happened then, and what were the results of that encounter?
He did a few physical tests of me, and after about maybe a half hour or so, he looked at my husband and I and said, I believe you have Parkinson's. And he was very firm about it. He came back to us after he let us kind of absorb what was going on and gave us some details as to why he thought I had Parkinson's, and assured us that there was things that they could do for us. And I did have an MRI on my brain to rule out any tumors, and thankfully there were none of those. And that was July 31st, 2011.
Okay, stay with us, Linda, if you would. Thank you for telling us your story. It's one that I'm sure many people on the line can relate to. And let me bring back into our conversation now Dr. Kathleen Shannon, who is heard this story, I'm sure, many times before. And Dr. Shannon, tell us your reaction to Linda's story, how typical it sounds to you.
Well, first of all, let me thank you also for letting me participate in this webinar. I'm going to mute you for a second because I have a train coming. Sorry, we're right by the elevated tracks here in Chicago. This is a really common story for us to hear. So in our day of specialized medicine, people tend to have a symptom. It doesn't seem like a brain symptom to them. It may not seem like a brain symptom to their doctor, and they've picked the specialist who sounds like the right one. And often that is an orthopedic surgeon. And often because it's a very common first symptom for our patients to have either shoulder or arm pain. And there are lots of other subtle symptoms that can happen before people have what are obviously neurological complaints. So it's fairly common.
And is also common that sense that Linda was describing of, well, why in the world would I want to see a neurologist? There's nothing wrong with my brain.
Well, exactly, because people don't think that arm pain can be from the brain because it seems like it's right in the arm where all the muscles and joints are. So that's a really common thing. And also people, I think it's fairly common that people don't have a sense of what the whole spectrum of neurologic symptoms are. They think maybe things like headache or epilepsy or stroke, but not other symptoms like slowness or stiffness or pain in various places. They don't think about that as a brain symptom.
And before we get to the kinds of things that you do and other movement disorder specialists do when someone like Linda comes into your office, there's another part of Linda's story that interested me, which was she said she went to the local neurologist. And not to cast aspersions on that individual or anyone else, but how important is it that people see someone who has a specific background and training in movement disorders as opposed to a more general neurologist?
Well, once again, it's hard to know who the right person to see is, but the reason that we think our patients are best handled by true experts is that we have the time to listen to people. So our appointments are usually longer than the appointments of a general neurologist. We spend pretty much all day immersed in thinking about the symptoms and signs and treatments of Parkinson's disease. So, and we've heard a lot of stories before, so the stories have that ring of truth to us. And in neurology, you're pretty much making all your diagnoses by history and physical examination. So it's that experience of listening to people and hearing the similarity in symptoms and tying them all in together into a nice, neat diagnosis is something that someone who listens to it all day is just plain better at. And there's data to support that being followed by a specialist actually improves outcomes. So the risk of hip fracture and nursing home placement, those kinds of things is much less in people who are followed by specialists than people who are followed by generalists.
So let's go to what the kind of things that you and other movement disorder specialists do. And we see on the screen now this phrase, diagnosis by observation, and that PD is diagnosed by way of clinical exam. And when you and I talked once earlier, I remember you saying that in and of itself is sort of a surprise to people because they're expecting something like any other disease that they might be seeing a specialist about, that there ought to be a blood test. What is that sort of expectation, I guess, that people often come to the office with?
So yes, I think it's really common so we spend a lot of time in our appointment on the front end, the history and the physical part. And it's in this day and age, there's a scan for everything and a blood test for everything, and it's comforting to people to see a number on a page or a picture on a screen. But we're not at that point yet where we have a way to diagnose Parkinson's disease that doesn't involve the history and the physical examination. And it's hard for people a little bit to accept that it's not 100% accurate, that diagnosis either. And it takes some time often to be certain about the diagnosis. That can be a little bit hard to accept in our current day and age where things are immediate more than delayed. But it gives us the opportunity to make a relationship with our patients, because once you find your specialist, you're going to be with that person for 20 or more years. So there's a lot of stuff that goes on in that initial appointment that's much more important as far as laying that foundation for a relationship and helping the patient to kind of accept and adapt to the diagnosis. Than there would be if this person just scribbled a test on a prescription pad and off you went to get your number on a sheet.
So, and as you suggest, that relationship, I think, for any of us who have gone through that or are in that process, know how key it is to build that relationship and to have that sort of sense of trust. As Linda was describing also, that she had to find someone who met what her particular needs are. But let's begin to talk about where we are now, and then we'll get into where we hope we can go with the diagnostic process. One of the first things that is sometimes done is something that you're testing for in terms of what's called postural instability. Tell us more about what that particular test is.
Well, the first thing, it's kind of a two-step process to diagnose a person with Parkinson's. One is to identify the presence of a group of symptoms that we tie together and call Parkinsonism. So these are 3 different symptoms that we're going to go through one by each. And then once you determine the person has Parkinsonism, that is the presence of those symptoms, then you need to figure out what disease or other process is causing that Parkinsonism. So postural instability is a very important aspect of Parkinson's disease, and it's really a difficulty in putting together the response to a threat. So, for example, in your daily life, if you were to trip over a curb, you have a whole series of things that the brain triggers to prevent you from falling, and you don't even need to think about those. These are reflexes, that we call postural reflexes. So people with Parkinson's disease often have a loss of these postural reflexes. They may, in their daily life, feel that as falling or tripping, but the way we test it in the office is we stand behind the patient. The patient stands with a comfortable stance, feet kind of shoulder-width apart, and we pull backwards sharply on the shoulders or push back on the chest to pull them off. They have to be off balance, and then we check to see if that rescue reaction comes in. So a person with normal postural reflexes will take a couple of steps backwards but won't fall, and a person with abnormal postural reflexes may actually fall or have to take many more steps or be caught by the person behind them. So that's something that the specialists do that people who don't understand Parkinson's don't often do, and it's an important thing. But it's not one of the early signs of Parkinson's disease. That tends to be a little bit later. But it's important because there's disability associated with the tendency to fall, so it's important for us to measure that.
And is it something that you can measure by degrees? You know, it sounds like you either fall or you don't, but is part of what you're looking for is sort of gradations of someone's stability?
Right. We actually grade it on a scale of 0 to 4, 0 being normal, 1 meaning takes a few steps back but doesn't fall, 2 meaning takes a few steps back and has difficulty correcting. So it's kind of a severity scale, and a person with a 4 is unable to catch themselves and would fall if they weren't caught. And they usually can't even stand on them. So it's kind of a gradation of scale. But what we're looking for when we're diagnosing is presence or absence. When we're looking for severity, we'll use those numbers at 0 to 4.
And the next point in this that is appearing on the screen now is rigidity. What are you looking for there?
So when we look for rigidity, it's defined as an increase in the tone, the resting tone of the muscles. So what we do is we take the person's arm or leg and we move it passively. We tell the person to be relaxed, not to fight us, and we move it passively, and we know what it feels like. It's very loose normally when you move a person's joints. And then in a person with Parkinson's disease, you will feel a resistance to that. And again, we're looking for presence or absence of that when we make a diagnosis, but particularly when we're looking at disease progression, and in research studies, we'll grade that on a scale of 0 being normal and 4 being severe rigidity. And we'll look at it in usually the neck, both arms, and both legs.
And then we've got a series of things about slowness of voluntary movement. There's an image of someone on the screen now that all of us who have gone through these tests know very well, which is the finger tapping test. Sorry, it disappeared on the screen there for a moment. Hopefully it's back now. Well, we seem to be having a bit of trouble. Sorry, folks, along the line if you're not seeing our slides at the moment. But why don't you go ahead and describe that, Kathleen, while we try to rescue our slide process.
So probably the most important sign of Parkinson's disease is what we call bradykinesia. Brady means slow and kinesia means movement. But it refers to several different abnormalities in movement, like delayed initiation of a voluntary movement, like taking longer to get the movement started, low amplitude or size of the movement, tendency for the movement to be slow and to kind of peter out. So we tend to look at repetitive movements, like asking the patient to tap their thumb to their index finger repeatedly for 10 seconds, or tapping the toes on the floor, or stamping the heel on the floor. And then we look to see if there's slowness, a tendency for the movement to fatigue or to peter out. And once again, we're looking for presence or absence of bradykinesia, but we have a rating scale that will grade that from normal to severe.
And when it says PEG transfer, I'm not clear on what that actually would involve.
Right. PEG transfer isn't something that's used in the clinic for diagnosis. At least I don't use it. But it's used in clinical trials, the research studies looking at drugs, for example. And you have a little container of little pegs, and then you have to put them in holes like a pegboard, and to see how fast. So that's something that could be measured as kind of an outcome measure to see whether a drug is working, for example. But I don't use that for diagnosis. I don't know any clinicians who do.
And what about the standard of tremor and resting tremor, and how does that fit into this constellation of things that you're looking at?
So the fourth of these clinical signs is tremor. Tremor just refers to a back and forth movement around a joint, or shaking would be kind of the vernacular word for that. And the tremor of and about 80% of people with Parkinson's disease have tremor, not everyone. And the typical tremor is one at rest. So if the person is sitting with the legs on the floor, the foot might shake, or if you're resting with your hands in your lap, the hands or one or the other hand might shake. And it's got a particular frequency too. It shakes about 4 to 6 times per second, and an experienced neurologist can kind of grade that just based on its appearance. And one of the hallmark features of Parkinson's disease that's not really mentioned on this slide is that it's an asymmetrical disease. So Linda mentioned that she had this pain in the neck and the one arm. It wasn't both arms. And then usually when the neurologist sees the person, they'll see that this slowness and stiffness and tremor are in one side, not in both sides at the beginning. And that's a very characteristic feature of the disease, one thing that we always look for in the examination.
And one thing that starts to become clear as we talk through all of this, as much scaling and scientific observation as there is in all of this, it also seems to me that there's a bit of art to it, that there's as much, in some ways, art as science, because we don't have that blood test or that particular scan yet that would necessarily do the trick. Is that a fair observation, that it really takes kind of a keen eye that can put all of this together, because there isn't necessarily the number that we normally associate as being associated with a particular definitive diagnosis?
Absolutely. It's really a lot of neurology is pattern recognition, seeing something and just knowing that you've seen it before and what it means. And it's with any disease that's diagnosed clinically, which is the case for Parkinson's disease, it really does depend quite a bit on the experience and expertise of the person who's examining the patient. But don't forget, a big part of this is listening to the patient too, because the patient tells you things that you don't necessarily see in the office. So no one could see Linda's shoulder pain, for example. That's a really telling symptom to us. That symptom means a lot to me, to hear it from the patient. So it's a combination of a good ear and a good eye.
Yeah, well put. So let's begin to look at some of the newer advances and where we are with those and what they tell us and where we hope to go. And as we get into this next area that we're going to discuss, which has to do with particular kinds of scans, I want to encourage everyone to also put down your questions. In about 10 minutes, we'll start taking questions from those of you on the line today. So in the box where you see where you can place your question or concern, please go ahead and enter that, and we'll start taking those questions in just a few moments. But let me bring Mark Frazier back into our conversation at this point. Mark, again, is the Vice President of Research Programs at the Michael J. Fox Foundation. And Mark, let's have you describe what we're now seeing on the screen, which is a newer kind of scan called a DaTscan, which measures and looks at the amount of dopamine activity in the brain. Tell us, we're going to learn something about what it tells us, and then we're going to learn something about what it doesn't necessarily tell us and its limitations. But first describe what we're seeing, the normal on the left and the abnormal on the right.
Sure. So DaTscan is a tool that was recently approved in the U.S. It's been used in Europe for some time, but it's a brain scan tool. This tool allows one to visualize the level of or activity of dopamine in the brain. I don't see it now, but on the picture, what the picture was showing, there it is. On the left side is an illustration of what's typically seen in what is quote-unquote a normal scan in someone without Parkinson's disease. And the area to look at is the area in the pink and yellow. That is lighting up and illuminating the dopamine in the brain and in an area called the putamen. And in someone without Parkinson's disease, it's typically, you can see what they call, the manufacturer calls a comma shape. It looks like a comma on the left and right side. And compared to the picture on the right, which is what's typically seen in a abnormal scan or someone with Parkinson's disease, the comma now is reduced to more of a period, and that's a reflection of lower dopamine activity in the brain, in that brain area, lower dopamine levels in the brain area. So the brain scan can indicate whether someone has a normal dopamine activity or an abnormal dopamine activity.
But these, Mark, are also more they're at each end of the spectrum, right? I mean, and part of what is of importance to note here is that period on the right could be a tiny dot, it could be a big period, it could be something that starts to approach looking like a comma, right? We're looking at sort of the clearest examples on either end of the spectrum, but they're not always that definitive.
Exactly, and that I think is a limitation of this tool in diagnosis. Like the clinical symptoms that are variable from one person to the other. Some people have shoulder pain, some people have tremors, some people have both, as Dr. Shannon described. There's a lot of variability on the brain scan, and what you're seeing here in these two pictures I think are probably two on the extreme level, where the normal scan is probably the ideal situation and the abnormal scan is pretty robust loss of dopamine activity. But within those ends of the spectrum, I think there's a lot of variability from patient to patient, person to person, and that's where the limitations of this brain imaging tool come into play. And so you are still relying on a visual interpretation of a clinician to interpret what they're seeing on the scan and help with the diagnosis in partnership with the neurologist.
So Kathleen, Shannon, when you see these, is that how you think of them as well? Is that it's another arrow in the quiver, but it's not something that really trumps what that constellation of symptoms that you takes, as you put it, both a keen ear and a keen eye?
Right. The main problem with this imaging study is it doesn't give you more information necessarily than you've already learned from the history and physical examination. So it's important to understand that this test was not approved for the diagnosis of Parkinson's disease. The FDA approved it as a way to image a low dopamine state. So dopamine, it's only part of Parkinson's disease, but that's the chemical imbalance that results, low dopamine is the chemical imbalance that results in those symptoms that we saw on the prior slide. So I do a history and examination and determine the patient has low dopamine. The scan also determines the patient has low dopamine. But what it doesn't tell you is if that low dopamine is due to Parkinson's disease or some other reason. And there are other diseases that look superficially like Parkinson's and have low dopamine but aren't Parkinson's disease. And one of the big limitations of the scan is while it helps you to tell between a normal dopamine state and a low dopamine state, it doesn't necessarily help you with the harder challenge, which is deciding if it's Parkinson's disease or some other disease that's caused the low dopamine state. So that's really the biggest problem that I see with the scan. And then the second thing is that, people wonder how accurate this scan is. Well, in order to know how accurate something is, you have to have a gold standard to compare it to. So you have to have something that's 100% accurate to know if your test is 90% as good as the truth. It's called the standard of truth. And the only standard of truth we have in diagnosing Parkinson's disease is the expert clinical diagnosis. So all these estimates of how accurate the test is are all based on a comparison to an expert. So in fact, the test is accurate. It's almost as good as the clinical diagnosis we make in the office, which is the gold standard. So in the hands of a person who's not really an expert with PD, who doesn't have a whole lot of experience and can't recognize those signs, it can be helpful in that first step of determining if the person is normal or has low dopamine. But for an expert, it doesn't actually add much to the diagnosis. And I have never ordered a DaTscan. It's been out for 2 years.
Well, that's just where I was going with that. Is there, because patients, I remember feeling this way. I wanted something. I wanted a scan. It's that old desire to have something that you can look at or quantify. In your judgment, then, at this point, is there really no reason for patients to request a DaTscan?
I think that there are a few people for whom the clinical diagnosis is difficult. So, for example, people who have a very unusual tremor. It's just like it's something that's not the everyday kind of tremor. Sometimes it can be hard to be precise about that diagnosis. And occasionally people who have complicated medical issues and maybe on certain drugs, sometimes it's useful there. But I have yet to find a person that I thought I needed that test for. But having said that, I mean, if the doctor's not sure and really would like a confirmation that the dopamine state is low, I think it could be a reasonable test. But it's expensive and it's radiation, and for the same price, you could probably go see an expert and have a lovely meal and maybe even a nice hotel room. So
which might be as useful in terms of how you are managing your disease as another test result.
Might be looking at a picture. Yeah.
Yeah. Let's move to a new additional. Sorry, we're having some trouble this morning, folks, with getting our slides to advance. It just seems to be that kind of day. We're trying to get to our next series. Let me see if I can do something else here and get where we want to go. Bear with me. We're jumping around here. Here we go. All right. This is going to take us to a new development in trying to get a clearer picture of the disease. And Mark Fraser, let's go back to you on this. This is the idea of being able to measure something else that's going on in the brain, which is this sticky protein known as alpha-synuclein that clumps up in the brains of people with Parkinson's, forming this item called a Lewy body. And the hope is that we can figure out a way to trace that, right, and get a better read on the amount of alpha-synuclein that might be in someone's brain. Tell us what that would do. This idea of coming up with an alpha-synuclein tracer.
Sure. So, yeah, as you mentioned, alpha-synuclein accumulates in Parkinson's disease in these clumps called Lewy bodies. And it is one of the hallmarks of Parkinson's disease. Currently, the only way to see alpha-synuclein in the brain is once a person passes away and to look at someone's brain under the microscope. But if we were able to actually visualize the presence of alpha-synuclein or the presence of these clumps of Lewy bodies in someone living with an imaging agent, just like DaTscan is an imaging agent, you could actually see the pathology within the brain as it accumulates, and potentially if it progresses with the course of the disease. So it really gets a little closer to the pathology of the brain in Parkinson's, what's happening in the brain in Parkinson's disease, and it gives you a sense of it could be a sense of whether a drug is making a difference in the alpha-synuclein accumulation in the brain. So the Fox Foundation and others have funded a lot of work in this area and to try to develop a imaging agent that could be used as a scan that could visualize the accumulation of alpha-synuclein in a living person.
And it would look a bit like what we're seeing in what's already happened in Alzheimer's disease, where they've been able to develop a tracer that tracks a different protein, the amyloid beta protein. And so, Mark, then you would have something that would be equivalent to this, like what we're seeing on the screen now, only instead of for Alzheimer's, it would give us the same kind of readout on Parkinson's?
Right, that's the idea. So in this picture that you're seeing on the left side are two pictures of someone without Alzheimer's disease, and what you want to look at is these red areas, and the red areas are illuminating a protein called amyloid that accumulates in Alzheimer's disease and clumps in Alzheimer's disease. And so on the right side is someone with Alzheimer's disease, and you can see this drastic increase in the red that reflects the accumulation of amyloid in Alzheimer's. And this has really revolutionized drug development in Alzheimer's disease, and been able to allow researchers to really visualize this accumulation of the pathology as it occurs, and determine whether experimental treatments may reduce that accumulation. And so the goal for Parkinson's disease is to develop a similar way to scan the brain to visualize alpha-synuclein.
So that the reason why it's revolutionizing drug development is that you now would have for the first time a readout on whether or not a particular drug might be working. So imagine this is a scan for alpha-synuclein and Parkinson's, what we're looking at the screen now. It would allow you in the future, and sorry, once again, our slides are disappearing. There's a ghost at work today. We'll just have to kind of keep going here and hope we can get back to where we were. We'll stay with the alpha-synuclein idea here, but the idea would be then that if you could do the same as we're seeing in the example from Alzheimer's disease, that red on the screen that we're looking at now, if you got the right drug, it would begin to diminish the red. So you'd actually get a readout. Is that the idea, Mark?
That is the idea, and if you can imagine a scenario where the red on the right side on the red may be an untreated individual, and the left side may be someone treated with an experimental therapy, which would allow you to really illustrate that your experimental drug is reducing the pathology that's associated with the disease with Parkinson's. So it would be a really useful tool, an indicator of sorts, to know whether your drug is working, and it would complement, obviously, the clinical readout, which is it actually impacting and improving the symptoms of Parkinson's.
And Kathleen Shannon, then, would that get us closer to the kind of gold standard that you were describing before? Can you imagine how this then, as a clinician and as a researcher, that this would be potentially a much more useful device?
I think there are a couple of things to say, and one is that unlike the DaTscan, which just tells you about the state of a chemical and not exactly how that chemical got to be in that state, this alpha-synuclein appears to be the most important aspect of the brain changes in Parkinson's disease. So it accumulates in the cells, they become sick and die. So it's very specific for the disease as far as we know. And it's a crucial, so it's not just a marker, but it seems to be a crucial determinant of sickness of the brain cells and death of the brain cells. And the second thing is we are pretty sure for a lot of reasons that the changes in the brain in Parkinson's disease start at least 5 years before we can detect the disease clinically, before the patient can detect any specific symptoms. And we've been trying to find something to slow disease progression in Parkinson's disease since the mid-1980s and have failed on many, many occasions. And part of it may be that by the time we can diagnose the disease, it may be too late for our intervention to be effective. And so one thing that we're trying to do is to find techniques that will allow us to identify patients who are destined to develop those characteristic signs and symptoms, and then find a way to intervene earlier. So it may be that if we can figure out who we would screen and do this kind of imaging, that we could identify people before they develop neurologic signs and symptoms and intervene earlier. And that's really a huge goal, I think. And we don't have anything yet that will slow that, but we have to think about the future, that we're going to develop targets and drugs and need to be able to identify people earlier. So that's a really huge thing. And then whether using imaging is kind of an outcome to determine if your drug works really depends on if the intervention affects the scan in the same way as it affects the disease. So sometimes a scan can be a marker and not tell you that your intervention's working. But that's all something to figure out in the future. And one thing, the Alzheimer's disease literature has shown that there are people from families with Alzheimer's, for example, that do show clear changes in their imaging before they develop changes in their thinking and memory. So there's a good evidence that we may be leading down this path if we can find the right tool for early.
And one of the reasons why alpha-synuclein is so central, as you're suggesting, and we're seeing on this last slide, and then we'll go to all our questions, is that alpha-synuclein is not just something that accumulates in the brain, it's something that shows up in the GI tract, and that may be an early warning sign too. Problems with constipation may be linked to that, right, Kathleen? So it's a pervasive entity, and if we could pick up on it sooner, whether that's by way of brain scan or other tests, it could be our earliest warning device or warning sign. So is that part of why we want to focus so much on that?
Well, I mean, it is the most important thing as far as we know. It's the triggering event. Then everything goes bad from there once that synuclein starts to accumulate in certain cells. But it's true that we can see synuclein in other tissues. So you can see it in salivary gland, you can see it in the stomach and the entire length of the intestines. You can see it in the skin, and so my particular interest is in looking at it in the intestinal system because we're trying to see whether the intestinal system actually is the source of the problem to start with in Parkinson's disease. But even if it doesn't turn out to be, it may be useful to identify people who are accumulators of the synuclein, and then once again to find an early intervention. So this kind of research, which is particularly exciting, is being carried on really at lots of places across the world to see if we can find specific changes in people that will predict. So one study that we did, we found that people who'd had intestinal tissue taken before they developed signs of Parkinson's already had that synuclein in the nerve cells in the wall of the intestine. And we're trying to work more on that to see if we could identify people before they get sick by doing biopsies of their intestines. And that's particularly interesting because everyone who gets to the age of 50 is supposed to have a colonoscopy, and so there's actually a ready source of tissue if you could figure out how to screen.
Let's go to our questions. Mark asks first, how close are we to being able to diagnose Parkinson's from alpha-synuclein aggregation, even from something as simple as skin cells? Mark, do you want to take that first, and then Kathleen chime in?
Sure. This is probably, well, I'm sure there's differences of opinion depending on which researchers you ask. As far as the imaging tool to be able to visualize alpha-synuclein, some of the support that some of the research that we've supported, it looks pretty promising. We'd like to, ideally, the earliest I think we'd be able to test an imaging agent in humans is in early 2015. So I think that's ambitious but potentially possible, and that would really just be very exploratory studies, not close to actually being used in clinical practice. As far as the peripheral system and things like skin or colon, I think that's probably a little further away. There needs to be a little bit more research on how consistent and common these observations are, and that's, I think, one of the focuses of Dr. Shannon's research, because as I mentioned with imaging and symptoms, this is variable from one person to the next, and so I think we just need a larger sample size to really see how consistent this observation of accumulation of alpha-synuclein in these peripheral organs really is.
I agree.
What would you add to that, Dr. Shannon?
I agree 100% with that. We need a lot more data, and there are only a few groups really that are working on this in earnest, and we're trying to collect more data and get more information about that. And one part of that is, and the Fox Foundation is involved in this effort, is in trying to kind of standardize and see if the different labs are doing things the same and if the results are kind of generalizable across different centers. So I agree that we're still kind of early, but it's not any less exciting because it's early. Still exciting.
Here's a question from Tricia, which is gets at whether or not we're able to determine yet whether or not your disease is going to progress more quickly. So it's a question not so much about diagnosis, but we've talked often in previous webinars that Parkinson has kind of a broad array of progression, and that some people progress more quickly than others, just as we know people have great variety in their symptoms. So the question from Tricia is whether or not, Kathleen Shannon, you're able early on to get a sense of whether or not someone is going to progress quicker than another.
That's a great question, Tricia. And the answer is that there's an awful lot of variability from person to person in progression. Everyone progresses, and we're not exactly sure what those factors are that determine the rate. And we can't tell from an initial visit. Often we need about 3 to 5 years of working with a patient kind of under our belts to get an idea about how things are progressing. So I wish we could predict it better, and none of the scans or anything that we have now, so the DaTscan doesn't help us with this. Maybe the synuclein scan would help us with this, but right now it's just have to wait and see.
And is there, though, Mark, some knowledge that's being gained now about certain possible biomarkers indicating whether or not someone would be more prone to have one kind of symptom array than another?
Yeah, so the Parkinson's Progression Marker Initiative, which I think has been discussed on previous webinars, this is a large longitudinal study collecting a lot of clinical and imaging and biospecimen data from both people with Parkinson's and match-aged volunteers, healthy volunteers. And we're collecting information. This is a study that the Fox Foundation is sponsoring in partnership with some others. And we're collecting that information over 3 to 5 years. And so it is really a comprehensive data set that hopefully will illuminate some unique aspects of how the disease progresses and potentially may progress in different people, different ways. There's some initial data, very preliminary data that was just published several months ago from the initial analysis of spinal fluid markers, spinal fluid proteins in that study. And it suggested that there potentially were some differences in the spinal fluid markers that reflected the differences in symptoms. So in other words, people that had more posture and gait symptoms had differences in the protein markers compared to individuals that had more of a tremor presentation. And so I think it's provocative, it's very early, but this study will now track that data over 3 to 5 years in these people, and we're hoping that that will illuminate some really unique features about how different individuals progress.
It's a question from Jill, which is, would alpha-synuclein in the retina explain why some people with Parkinson's have blurred vision? It's one of the things we see on the screen, Kathleen Shannon, that alpha-synuclein is found. What do we know? And there's been some interesting some additional work early now on what eye movement can sometimes tell us. Bring us up to date on what we know about the eye and alpha-synuclein presence there.
Well, the vision in Parkinson's disease is really quite complicated. A lot of people have complaints, and there are several different reasons. So there is dopamine in the retina. That's why there's synuclein in the retina. And we know that people with Parkinson's disease have problems with contrast sensitivity, which can cause difficulty with reading, for example. They also can have problems with coordinating their eye movements, especially changing from a distance vision to a near vision, so can have double vision when reading. They don't do well with bifocals. So it's really kind of a complicated, multifactorial explanation for the vision problems. And often a good neuro-ophthalmologist, specialist in eye movements and vision can really help our patients out a lot. It's hard to say, I think, what's going to happen with the synuclein in the retina, how useful that's going to be, or even how it directly relates to the vision complaints.
It's a question from Patty, which is, who would the pool be who could have a scan before symptoms arise? And let me just broaden that out a bit, because one of the questions, of course, here is we want to get in on this as early as possible so that we might be able to stop the disease before it even starts. So would, in this case, I'm going to just extrapolate from Patty's question, an alpha-synuclein scan, Kathleen, be useful in someone perhaps where there may be a genetic connection to the disease, so that you could, in the future, sort of catch something early on? Or is that the kind of individual where you might want to engage in some sort of diagnostic testing before symptoms actually appear?
Well, most of the clues for this come from a really interesting study called the Honolulu Aging Study, which collected data over time on men living in Hawaii, men of Japanese ancestry living in Hawaii, and then saw who among them developed Parkinson's disease and could go back and see what those really, really early symptoms and signs might be. And so they kind of identified some symptoms that people might have up to 15 years maybe before diagnosis, and these things are things like constipation that doesn't get better when you use laxatives, and excessive daytime sleepiness, and anxiety or depression, and loss of sense of smell. And so one of the things that there's a study called the PARS study, the Parkinson's at Risk study, that's using imaging sort of like the DaTscan in people who have some of these, who have loss of sense of smell. One of the goals of that study is to see whether we can identify people who might be at higher risk of showing abnormal imaging. So those are the kinds of things that we're looking at, as the presence of those symptoms. But I think it's a little soon to know, because in something like that, most of the people with abnormal sense of smell will not, in fact, develop Parkinson's disease. Most of the people who are first-degree relatives of people with Parkinson's will not develop Parkinson's disease. So you need to find a way to narrow that down and find the highest yield population to screen, and then decide which of the screening tests is the most accurate. So there's a lot of work to be done there, but there's some very intriguing preliminary research, and people are working very hard on this. I think we'll see some real results coming out in the next 5 years on this.
And Mark, there are a number of questions about what exactly alpha-synuclein is. Fred wants to know whether or not it's a useful protein in a normal, healthy body. Judy wants to know whether or not it's found in all humans, or if it just is something that accumulates in people with Parkinson's. So can you give us just a very brief kind of alpha-synuclein 101?
Sure. It's a great question, and something that researchers are really trying to figure out. It's a tough nut to crack. But what we know about alpha-synuclein so far is that it is in every human being. It's found in a number of different tissues throughout the body. It's found actually at a pretty high percentage in the brain, so it's found at high levels in just a normal brain. What we know about alpha-synuclein in terms of function is that we think, at least within dopamine brain cells, it's involved in the release of dopamine from the cell, and this has implications on how dopamine as a neurochemical signals and communicates with other brain cells. So we think it's involved in release of dopamine. It does accumulate in Parkinson's disease abnormally, so typically in the normal brain it exists in just a single form, but in Parkinson's disease and some other movement disorders it accumulates, it clumps up abnormally, so there's multiple synucleins all together in this clump. But that's what we know so far. I think there's a lot of studies going on to really understand why it changes from a normal functioning protein in the normal brain to abnormal accumulation and clumping in Parkinson's disease, and that's something we just don't know.
A couple of questions now that take us back to the DaTscan question. One individual wants to know whether or not there can be such a thing as false positives with DaTscans. Mark, can you answer that?
Yeah, I would be interested in Kathleen's input on this, because I think it's possible, but I don't know how common it is in the clinical setting.
So once again, the gold standard for this is the clinical diagnosis, and there are some false positives, but they're not very common. So if you think about how you describe accuracy of tests, should accurately pick up all those people who are affected. So all those tests should be positive, and 100% perfect test. Everyone with the disease would be positive, and no one without the disease would be positive. Everyone without the disease would be negative. And so when you're asking about false positives, you're asking how many people without the disease will show up a positive scan, and it's somewhere around 2% or 3%. That's considered a fairly specific test, but not perfect.
And is that, I mean, is it also the kind of problem where we saw in that earlier slide, which I'm going to attempt to get us back to, but I may or may not be successful. It doesn't look like I will be. We saw the comma in the period. It's the trick would be, I mean, you could have something that, maybe you get a semicolon. It doesn't look at least like it would be something that would be very clear cut necessarily one way or the other.
Right. The people who really developed these tests and who are still using it, these kinds of tests as research tools, they have a quantitative measure. So they can actually say 60% decrease or 40% decrease. But in the test that was approved and is commercially available, the reading is supposed to be normal or abnormal. And you can see, just like you say, that, abnormal could be a whole spectrum from a very mild abnormality all the way up to a severe abnormality. And I've seen tests from other places where the result, which is supposed to be positive or negative, will say indeterminate. Where the person just couldn't decide if it was positive or negative. So there is a little bit that has to do with interpretation. Maybe the person who's reading the scan, because it's a radiologist who reads the scan, maybe that person hasn't seen a lot of scans or doesn't have a lot of experience. But I'll tell you that in the studies that the FDA relied on for approval, the inter-rater reliability was pretty good. So if one reader said it was abnormal, then usually another reader was pretty likely to say it's abnormal. So, at least among people who are used to reading them, the agreement is pretty high.
Peggy asks, when do you suggest a person with symptoms such as long-term asymmetrical pain find a neurologist? Kathleen?
Oh, that's a really good question. Because we see the people once they come to us, not the hordes of people out there who might have asymmetrical pain. I think that's
Can you describe also what that is?
What do you mean, asymmetrical pain? Pain in is that what you're asking? Pain in one arm, like our shoulder. So like anything else, if there are 1,000 people with pain in the shoulder, I don't even know how many of them will turn out to have Parkinson's disease because I don't see them until they get to the neurologist. So I'm not sure that there's even any data to kind of decide. But when we see people, they don't just have pain. They have slowness. They have rigidity. So if you have pain and your handwriting is small and cramped, or you feel like you're not having as good dexterity with buttoning buttons, or you see any tremor, those are really the people who need to come to the neurologist because that's really the kind of high yield. Because what we see then, I'm sure, Linda, that when your neurologist saw you, it wasn't just pain. It was probably small finger taps, et cetera. So there are neurologic signs.
That's true.
And I think people
Linda,
have a tendency.
Bring you.
What I hear a lot is people will say, oh, I thought the tremor was from the shoulder pain, or I thought the tremor was from the neck pain. And, the doctor that they saw didn't have enough sophistication to realize that was really the neurological. There's always something neurological you can see if you know to look for it. But sometimes an orthopedist doesn't know to look for it. Or primary care doctor.
Linda, if you would, sorry to keep climbing over you, Kathleen. Linda, if you would rejoin our conversation because I want to get a quick closing comment from each of you. In terms of that, Linda, Kathleen was just referencing that you had probably had other associated things besides the shoulder pain. But give us, from your patient point of view, sort of your best advice to people who perhaps that person who has pain only. What would you suggest they do in terms of not only perhaps going to see a neurologist, but as you put it earlier, making sure they see someone who is responsive and who listens well, who has that, both as Kathleen put it, a keen ear as well as a keen eye?
I think that's the whole thing. You've got to get someone that you feel comfortable with, someone who listens to you, not talks over you, someone who's listening to you and is willing to, and all the symptoms. Because as Kathleen said, it wasn't just one thing. There were several things that were going on. And so you just, I think it's important not to wait as long as I did. If you suspect something, go right away. Because I just wish I had gone sooner and started taking medicine much sooner than I did.
Thank you. And Kathleen, a last comment from you about your hopes for where we'll get to in terms of getting to be able to define and diagnose more quickly, and underline again, if you would, why that's so important that we get in on this disease as early on as possible.
Well, as far as, I think that there are things that people need to do and can do if they get diagnosed earlier. It's not necessarily treatment at this point. We don't really know, if we could diagnose people 2 years earlier, whether there's some treatment that we could institute, because we just haven't found a neuroprotective thing. But it's very important for people to get on top of kind of education and exercise, learning about your disease, exercising every day when you're still in really good health and able to do that is a huge investment in the future. The more empowered you are, the more knowledgeable that you are, the more physically fit you are, the better the next 2 or 3 decades of your life are going to go. I can guarantee it, even if we don't make a lick of progress from now on, I can guarantee if people get on top of this disease and learn about it and exercise, they're going to do better. But it's really important for us. You might say, well, why is it important to find out if I have this abnormal scan if there's nothing that you can offer me that's going to change the difference? And I was just reminded of a Wayne Gretzky quote a couple days ago, which is, a good hockey player plays where the puck is, a great hockey player plays where the puck is going to be. So we are doing all this work because we know that in the not too distant future we're going to have something that we can offer people, and we need to lay the groundwork, and we need to figure out who's at higher risk, and we need to be able to diagnose earlier if we're ever going to make any kind of intervention.
And Mark Fraser, back to you as far as where the investments are going now in research, your hopes for when we might be able to have that alpha-synuclein tracer, which would give us perhaps both an earlier window into diagnosing the disease, but a way of tracking the disease and assessing whether or not particular drug treatments work. What's the next horizon for when we might expect that to become something that's really available and useful for patients?
Well, this is something that not just the Fox Foundation sees as a priority. If you talk to any drug company developing new treatments for Parkinson's, they will say we need better tools in our toolbox to more precisely diagnose Parkinson's, but also have a tool to know whether a experimental drug is working. And so this is extremely important, a priority for the Fox Foundation. We are supporting a number of projects to develop these tools called biomarkers that will be more objective tools to assist in the diagnosis and management and drug development research. I'm optimistic that through our efforts that there will be not just one tool, but a number of tools that will be used and arrows in the quiver of the neurologists and researchers developing these new treatments. I'm hopeful that within the next several years we'll have a number of research studies that will reveal new tools that are currently will be discovered. We're funding a lot of research going into discovery of new biomarkers, but also verification, standardization, and replication of some of these existing discoveries, which is equally as important. So I'm optimistic that in the next several years we will have those tools available.
And we are at the end of our time.
One little thing here.
Go ahead, Kathleen, briefly, yeah.
Which is that we talk about science and we talk about biomarkers. It's important to remember that those biomarkers are coming from people, and those research studies are coming from people who are getting scans. And we really are grateful and very dependent on the willingness of people to participate in clinical research. So I don't want to leave this webinar without putting this idea in your head that there are contributions you can make that will make a difference for you and for other people if you'll be willing to participate in research.
Thank you for adding that. You can see at the top of the slide there now that for more information on participating in clinical studies, you can go to the Fox Trial Finder site, and it's a great way of matching up where you are with research studies that are going on in your area and ones that you might be able to participate in, because it really is true what Kathleen says, that finding the answer really does depend on all of us. With that, we should bring our conversation to a close. Our apologies for the difficulty with the slides today. We'll do our best so that by the third Thursday Thursday of next month, we'll have that problem taken care of, and I hope you will join us then. So let me hand it back to Mark, who will wrap up our conversation. Mark?
Sure. Thank you, Dave, and thanks to everyone for joining us today. Also, special thanks to Dave, Linda, and Kathleen. Just a couple housekeeping items. We'll be sending a link to the webinar on demand if you want to listen to it again or share it with anyone. And in that link, there is also going to be a survey in that email. And so we really hope that you'll share your thoughts and feedback on today's presentation, as it will guide future webinars and presentations. So finally, mark your calendars for the next webinar, next third Thursday, which will occur on February 20th at 12 p.m. Eastern. Visit the Fox Foundation website, www.michaeljfox.org, for more information. Next month, we'll be talking about some of the non-motor symptoms of Parkinson's disease and the latest research around those. So thank you, everyone, for joining, and have a wonderful day. Bye-bye.